Good evening, everyone. Thank you for joining us today for our webinar on truth, the medical profession's first step towards reconciliation. I would like to welcome our speakers today, Dr. Lisa Monkman and Dr. Ainslie Mihalchuk. Dr. Monkman is a family physician and an Ojibwe member of Lake Manitoba First Nation. She has practiced in rural Manitoba her entire career. She is passionate about health equity, health justice, and eliminating racism in all forms, which motivated her to join CPSM's council in 2022. She is also the chair of the Truth and Reconciliation Advisory Circle. Dr. Ainslie Mihalchuk is a family physician who has been the Registrar and CEO of CPSM since July 1st. She spent over a decade in healthcare administration prior to joining CPSM as Assistant Registrar in 2020. A common anchor throughout her career has been a focus on quality of care and a commitment to creating better outcomes for patients receiving medical care and for the medical professionals delivering it. As Registrar and CEO, she draws on her experience in transformational leadership to shape regulation by fostering trust, accountability, and integrity in the medical profession. Now I am pleased to turn it over to Dr. Mihalchuk, who will begin with a land acknowledgement.
Thank you all for being here this evening. And yes, I do. We'll start with our land acknowledgement. We acknowledge we are gathered on Treaty 1 territory and that CPSM regulates the practice of medicine on the treaty territories of Treaty 1, Treaty 2, Treaty 3, Treaty 4, Treaty 5, and Treaty 5 adhesion. We recognize these are the ancestral lands of the Anishinaabe, Anishinaabe, Cree, Ojibwe, Dakota Oyate, Dene Solanè, and Heathwok nations, and the national homeland land of the Red River Métis. We acknowledge Northern Manitoba includes lands that were and are the ancestral lands of the Inuit. CPSM acknowledges and apologizes for its role contributing to the disproportionate health inequities that exist amongst the Indigenous communities in Manitoba. These failures include inadequately addressing Indigenous-specific racism by medical practitioners. We respect and celebrate the resilience and strength Manitoba's Indigenous people have displayed in the face of genocide and displacement of their communities. It is a privilege to regulate the practice of medicine on these lands, and CPSM pledges to improve. The first step to improving is continual acknowledgement of our respect for the spirit and intent of treaties and remaining committed to working in partnership with First Nations, Inuit, and Métis people in the spirit of truth, reconciliation, and collaboration. So this land acknowledgement was developed to be meaningful specifically for the medical profession. CPSM authored it, and it was shared with the advisory circle for their feedback and recommendation. And we have been using it routinely since June of 2023. In 2015, the Truth and Reconciliation Commission issued 94 calls to action, including 7 placing responsibilities on healthcare professional regulators to lead real change. Based on CPSM's mandate, values, and principles as a medical regulator, we knew we were in a position to answer those calls. Additionally, in September of 2021, the Federation of Medical Regulatory Authorities of Canada, or FEMRAC, and all 13 provincial and territorial medical regulatory authorities in Canada issued a statement committing to taking action against Indigenous-specific racism. I will acknowledge that we spent a long time reflecting on past harms inflicted on Indigenous people in the medical profession in Manitoba, listening to and learning from Indigenous people and their experiences with healthcare, and contemplating how to best move forward with meaningful actions. Finally, in June of 2021, CPSM made addressing Indigenous-specific racism in medical practice a strategic organizational priority. This required council approval and meant that we would commit time and resources as an organization to moving this important work forward.
So, bonjour everyone. It's an honor to be here today to talk about the collective work that we've done at CPSM. I just wanted to acknowledge the legacy that three important individuals left behind, and exemplify that we as a medical profession have to do better. So the first is Jordan River Anderson. It's not lost on us that yesterday, October 22nd, Jordan River Anderson would have been 25 years old. He was a First Nations child from Norway House Cree Nation in Manitoba. He was born with complex medical needs and spent more than 2 years unnecessarily in hospital, while the province of Manitoba and the federal government argued over who should pay for his at-home care. Sadly, Jordan died in hospital at the age of 5, never having spent a single day in a family home. So his life and journey inspired the creation of what we now know as Jordan's Principle, to ensure that First Nations kids receive the health care and social services they need without delay. The other individual we need to acknowledge is Brian Sinclair. So for those who don't know, Brian Sinclair was an Indigenous man who died at a Winnipeg hospital waiting for a very treatable medical condition. He presented after seeing his family physician and did everything right in order to access medical care. He died waiting 36 hours without having received any care at all. So if you want to read more about Brian Sinclair's life and death and the inquest that examined it, we recommend that all stakeholders in the health system, including the federal government, the provincial government, regional health authorities, unions, professional organizations, and post-secondary institutions involved in the delivery of professional programs, adopt anti-racist policies and implementation strategies that include committing resources to providing anti-racist training and supporting independent investigations when complaints are filed. So that came out of the inquiry to Brian Sinclair's death. And then Joyce Etchepon. So her death occurred in September 2020 in Quebec, near the community of Manawan. And an inquiry into her death resulted in the creation of what we know as Joyce's Principle, which is basically a call to action. It aims to guarantee all Indigenous people the right of equitable access without any discrimination to all social and health services, as well as the right to enjoy the best possible physical, mental, emotional, and spiritual health. So Joyce's Principle requires the recognition and respect of Indigenous people's traditional and living knowledge in all aspects of health. There was a recent CMA study published in the CMA Association Journal in April 2024 that found that in Alberta, emergency department visits by First Nations patients were more likely to end with them leaving without being seen or against medical advice than those by non-First Nations patients because of mistreatment. Leaving without care delays access to essential medical services and treatments. It delays continuity of care, and it increases health gaps and risk of death. And this is often how racism manifests in today's health system. If the environment is unsafe, then you're less likely to go there when you need what we value and love as Canadians, universal healthcare. So we know that we now have an opportunity to empower cultural changes required by the medical profession, and we recognize that this must be Indigenous-led. And so from the beginning, since the creation of the advisory circle, we gathered Indigenous physicians, scholars, elders, public representatives, and knowledge keepers, as well as other CPSM registrants to help guide the collective work. And the advisory circle that I currently chair at CPSM operates in a spirit of inclusion and respect for diversity. So that is why we had such a large working group at the table, and it's because there is such diversity within our amazing province. So we needed all the voices to be present. And basically, for the last few years, the CPSM Indigenous Advisory Circle has been providing advice, guidance, and recommendations to help CPSM reflect on processes, policies, and systems so that we can better understand and support Indigenous patients and guide the physicians who care for us. Collectively as a group, we identified 7 key areas of work. We recognize that we will not see change until all practitioners acknowledge how medical care is impacted by Indigenous specific racism.
In humility, we've committed to these 7 recommendations in our path to truth and reconciliation, and we are so grateful for Dr. Monkman's leadership and for the work of the advisory circle to continue to guide us as we work through these actions and try and develop meaningful actions for change. So in January of 2023, CPSM issued an apology to the Anishinaabe, Anishinaabe, Dakota Oyate, Dene Sulene, and Mihalchuk for racism experienced in their medical care in Manitoba. The apology was delivered in person at the Special Chiefs Assembly on Health Legislation hosted by the Assembly of Manitoba Chiefs on Treaty 1 territory. The apology was delivered by Dr. Mihalchuk, CPSM Registrar and CEO at the time, Dr. Jacoby Elliott, CPSM Council President at the time, and Dr. Ira Ripstein, the Council Past President at that time. And Dr. Lisa Monkman, Chair of the CPSM Truth and Reconciliation Advisory Council, delivered opening remarks. Subsequently, on February 28th, 2023, CPSM issued an apology to the Inuit for the racism experienced in their medical care in Manitoba. Dr. Lisa Monkman gave opening remarks, and Dr. Anna Shomek and Dr. Jacoby Elliott delivered the apology to the Manitoba Inuit Association staff and board members.
I think it's important to acknowledge the foundation of the apology. The reason why we recommended that as step 1 was to ensure a measure of kind of truth reckoning and accountability, and also to provide an opportunity for CPSM as an organization to develop relationships with Indigenous people and communities. And so, there are a variety of benefits from an apology. One is acknowledgement, accountability, and then the other piece of it is okay, so how can we then back that up with some action items and move forward in a meaningful way to make our health practitioners safer for all. So after the land acknowledgement, the apologies, and that kind of stuff, we divided ourselves up into some smaller groups. And an anti-racism standard of practice was one of the action items and areas of work that we really put a lot of thought and work into. So we hired an Indigenous consultant to help us navigate the many moving pieces of this work. I'm really proud of the work itself. So we created a standard and an amazing contextual document to ensure that Indigenous voices and perspectives were involved right from the beginning, guiding and informing the process. And there were many public consultations that occurred, and many revisions of the actual standard and contextual document as well. So this is the work of many that went into it. After we did the community work and the Indigenous perspectives, we consulted with Doctors Manitoba and then CMPA. And then it was ready for launching. So the initial principles obviously need to be evolved into a really more robust practice standard. And so that's where we went. Step 1 in terms of creating a document to learn was defining what anti-Indigenous racism means. So we could agree on what the common ground is. What does it look like? What does it feel like in the health system? And, what is the extent of the work that needs to be done? So it's easy to identify, personally mediated racism or stereotyping and discrimination in action on the part of an individual. But we know that racism is far beyond that. Racism is a structure and a system of inequity. Racism is absolutely more than individually mediated behaviors. And so the key highlights from the standard are really understanding what anti-Indigenous racism is and its impact on the health of Indigenous people. And I often relay the story of my late Aunt Sally. This was back in the 80s, but she was hit by a drunk driver walking home from a community event. And our family called the ambulance to bring her into hospital. So we lived in Bogar at the time. Bogar, Manitoba is a small Ojibwe community, 2 hours north of Winnipeg. And, the ambulance dispatch person on the other line said, okay, well, is she a status Indian? And because of the Indian Act and the sexist, racist laws that exist in our country, she had lost her status when she married my Uncle Dennis. And so we said, no, she's not a status Indian. And they said, well, we can't bill the federal government for this ambulance service, so is she at least on welfare? And the answer to that was also no, because my Uncle Dennis was a hard worker and he provided for the entire family. They're 3 small boys. He was pregnant, 8 months pregnant at that time. And so they said, well, we can't bill the province or the feds for this service, and we actually don't think the Indians in Bogar are well off enough to afford us, and then they denied us service. It took 3 hours before we were able to call for an ambulance from an outlying community. And by then it was too late, and she died. She bled to death at the side of the road, her and the baby. And so I often bring up this story, even though it's painful to reflect on and think about, because I ask my students when I teach them to think about who is at fault here. And I ask them to mull it over. And they often point fingers very quickly at the ambulance dispatch person, for denying care. But the fact of the matter is, if there wasn't the Indian Act, if there wasn't the policies of disenfranchisement, if there wasn't sexism rooted in the racist laws that govern Indigenous people in Canada, then that one person denying her access to medical care wouldn't have been as powerful as they were. And so I share the story today to honor her legacy, but also to remind everyone about, racism doesn't just hurt people's feelings. It actually ends people's lives. And it results in delays to medical care that is essential for Indigenous people to be healthy and well on our own lands, on our own original territory. And so the other highlight of the standard that I think is really important for everyone to know about is that in order to identify anti-Indigenous racism, not just acts, but also omissions, you need to be able to engage in a process of deep self-reflection. You need to be at a point in your practice where you have a very deep understanding of your patient in the context of their lives. And then you also need to be at a point where you're willing to do better and educate oneself. So the third tenet of the standard of practice is taking action to address acts or omissions of anti-Indigenous racism in the healthcare system. And this is aligned with our code of ethics and professionalism as doctors in Canada. And it's aligned with our commitment to advocacy. And it is also aligned with the essential need to have difficult conversations and report things when you see them occur.
So the restorative practices program is a really important piece of the standard and the implementation. I want to tell you a little bit about that. I do want to acknowledge that the Restorative Justice Working Group includes members from the Rady Faculty of Health Sciences and CPSM, and we've been working with knowledge keeper Leslie Spillett, who helps to ensure that our work is rooted in local teachings about restorative justice. So this restorative justice program emphasizes repairing or restoring relationships, fixing harm, and preventing further harm from occurring. And it's a collaborative and engaging process for all people involved, and it's intended to be positive and restorative using human first principles. We feel that using this kind of approach is crucial for the successful implementation of this standard. And at the end of the day, what we're talking about is changing human behavior and gaining insight into things that many of us just haven't had the need to see. And so the process is intended to empower individuals to do better and to move away from the fear that engaging with CPSM is going to result in discipline. So this program is going to focus, as I mentioned, on healing harm through a quality-focused approach, completely separate from the complaints and investigation process. It's intended to address anti-Indigenous racism concerns that may arise in the practice of medicine with an education and support first lens. And for those of you who aren't familiar, and I expect many of you are not, we currently have a program after which this is being modeled that operates in our quality department today. That program is called the Prescribing Practices Program, and it is a program that educates and supports registrants to enhance prescribing practices, and was actually developed to support the implementation of two different standards that have been around for a little while, the opioid and the benzodiazepine prescribing standards. So in this program, the approach allows for registrants either self-identified or referred by colleagues or other health professionals, or sometimes even patients, so that individual registrant can have a conversation with medical consultants and staff at CPSM to enhance their understanding and application of the standards without the fear of discipline. So in many cases, concerns like these would otherwise have gone to complaints and investigations, but we have developed ways to redirect them away from complaints and investigations so that we can focus first on education and constructive feedback, and not blaming and shaming individuals for needing education and support with something that's new or that's outside of their scope, or that they really haven't had the appropriate experience with. So we know this approach works. Last year, we had about 400 calls related to prescribing advice, and 85% of those cases resulted in either an educational intervention or advice was provided to enhance competency and make prescribing safer. But also what's really important is only 1% of those calls resulted in a referral to the registrar for consideration of discipline. So this is really about how do we help the profession do better and be better?
Can I comment on that? So restorative justice is a way of conflict resolution that is found, like its foundations are deeply rooted in Indigenous worldview and knowledge systems. And what it does is it's a process or a framework by which it seeks to restore the integrity and the humanity of both the perpetrators of harm and also the recipients of harm. And so both parties involved in any restorative process, if it's truly restorative, should walk away from it feeling better, knowing more, and actually being equipped with a skill set that will improve their ability to be in the world in a good way. And so the old way of like reporting like complaints and investigations was deeply punitive. And I don't know that it resulted in, like meaningful change, especially when we talk about addressing the harms caused by racism. And so I just wanted to highlight that piece of it because, obviously when harm happens, sometimes there are cases that need to go the punitive road.
Yes.
But, like one of the fundamental beliefs, Indigenous worldview that I grew up with was that like each human being carries an immense value and a unique skill set to leave this world a better place than they found it. And so I want to be a part of a process that helps people get there. And I believe like restorative practices are the way to do that type of work.
Thank you so much, Lisa. So I think that goes without saying then that is the foundation of what we're trying to achieve here is a safe space for education, to have discussions about behavioral change, insight, and at the end of the day, have meaningful impacts on patient care for Indigenous patients. And the plan is that the Restorative Practices Program will be led by someone with expertise in anti-Indigenous health-related racism and restorative practices, and we're hoping that will be a registrant. The expected timeline for the rollout of this program would be aligned with the launch of the standard of practice, hopefully early in 2025. But further to comment on the harm piece and how the goal of our processes could be shifted away from that punitive aspect, we're actually working to build the restorative practices into our complaints process so that there's an opportunity for an alternative dispute resolution that does bring two parties together for a meaningful healing opportunity on the other side of harm, and to learn and hear each other's perspectives. Really, it's about learning about each other's humanity. And we've been working for a while now with CMPA to explain this novel approach and to work with them to help understand what this might mean for registrants. And those conversations and work has been going very, very well. We expect this will further progress and accelerate once we have someone in the role within the restorative practices program. But this is not only to support the standard on the quality side, but also to offer new ways for us to deal with the resolution of concerns that are brought forward to the complaints department in a non-punitive, non-disciplinary way. So another core component to our plans as they have been outlined is through mandatory and Indigenous racism training. So for those of you who aren't aware, Statistics Canada data shows that Manitoba's population has the highest share of Indigenous people, and Winnipeg is home to the largest Indigenous population in Canada. So while many of our Manitoba educated medical graduates from recent years have had comprehensive training in Indigenous healthcare, others have had no training or no background on the topic. And it's really important that we establish a baseline of Indigenous intercultural competence in Manitoba. This will provide a common base of understanding and knowledge on the issues that reconciliation seeks to address and to assist in interactions with Indigenous patients and Indigenous medical practitioners. So at this time, we haven't finalized what this will look like. We have to consider what are the options for this training, and we'll talk a little bit about one of the new options for the training, what the time frame will be for completion that will be realistic, what might be the repeat cycle, so how often might this education need to be repeated, what are some of the exclusion criteria for why some individuals may not need to take that training, or what might be other options aside from the training that would meet the requirement, and then to acknowledge that different individuals would have varying degrees of learning needs. So this is still a work in progress, but it is something that we're committed to, recognizing that in order to enact the standard, we really have to have that common understanding of what the lived experience is and history and the truth.
Yes. So for those who don't like the word cultural competency, please know that we don't expect anyone to be experts in anyone else's culture. Like, that's not what we're getting at here. Like, this is an anti-racism standard of practice, and part and parcel to anti-racism is understanding your position of power and privilege in the healthcare encounter, and then also within the health system. And so the U of M actually is doing an amazing job of launching a learning program to help support this. They are going to be launching very soon a program called Gika Mino Ganawene Manishnavik, which translates into "we will take good care of the people." So it's been developed by Ongamazin, the Institute of Indigenous Health and Healing at the U of M Rady Faculty of Health Sciences, in partnership with Manitoba's health system. So it is an anti-racism training program. It's asynchronous. There's 10 online modules. You will be provided lots of opportunity for deep self-reflection and an online coach. One of the sessions will be in person. So if you already work with one of the health partners, you may have access to it soon, and others may have paid access. So that's basically a good opportunity to use your CME rebate Manitoba.
So in terms of what other actions are taking place across the country, I'm sure many of you are aware the CMA has just issued an apology on September 18th for its role in the role of the medical profession in the past and ongoing harms caused to First Nations, Inuit, and Métis people in the health system. This apology was delivered at a ceremony in Victoria, BC, which Dr. Monkman was at, on the traditional territory of the Kwagan-speaking people of Songhees and Swatepsum nations, and shared publicly via live stream. Another important piece of work that's been going on across the country is the CPSBC standard of practice. So this was a standard of practice that was adopted by multiple different health professions, and it came out in 2022, called the Indigenous Cultural Safety, Cultural Humility, and Anti-Racism Practice Standard. Their development process was similar to ours in that they engaged their Indigenous partners from First Nations and consulted with key audiences, including Indigenous patients and registrants and the First Nations Health Authority in BC. They certainly reviewed many of the same documents that we have used as important sources of truth. And those would be the In Plain Sight report and the 94 calls to action that we referenced previously. And like us, they are also offering resources to help registrants learn, grow, and improve with respect to practicing in an anti-racist way. So just wanting to highlight again our path. So our first commitment to taking meaningful action took place in 2021 by making addressing anti-Indigenous racism a strategic organizational priority. We developed our Truth and Reconciliation Advisory Circle. In 2022, we identified those 7 actions that we've been working through. In 2023, our land acknowledgement was completed and our statements of apology were delivered. Now we're at the place we're working on the definition of anti-Indigenous racism and the standard of practice. And we look forward to launching that standard in 2025 in coordination with the Restorative Practices Program. So what we know at CPSM is that our path to reconciliation is not linear. It is a continual process and that it does not have a clear endpoint. This is our work in perpetuity, and the reality is our continued collective actions will all lead to meaningful change. And it's very important that we do this work as our we have such an opportunity here to have an impact. Yeah. So if you haven't had an opportunity or haven't taken the time yet, we really do appreciate your review of the standard and providing feedback. You can email your comments to the address that's listed on that slide. I just want to acknowledge that, self-regulation is an incredible privilege that we have. It's not something that we are guaranteed, and all of us need to engage in good self-regulatory behaviors in order to protect that privilege. And so by joining us this evening and engaging in the review and understanding the standard, these are really good self-regulatory behaviors. And this, at the end of the day, is the foundation for that privilege that we all have to hold each other accountable. CPSM employs 10 doctors, and our job is to oversee the self-regulatory work of over 3,300 of U.S. practicing registrants. And so the reality is the job of self-regulation is all of our work. And we can make meaningful change if we work together to support each other to be better and do better in practice. So appreciate all of you joining us this evening and your engagement and willingness to be here with us. Yeah. And we're happy to try and answer any questions that you may have.
Mm-hmm. Before we go to the questions, I just really want to thank all the Indigenous folks who gave so generously of their hearts, their stories, and their time, their precious time. You know, it's not easy to help teach others about what racism looks and feels like. And it's not lost on me, like how painful that can be but every person on the committee is like a tremendously hopeful human, so I just feel like this whole process was actually, in my opinion, a really robust learning and example of good allyship. So I feel really proud of the work of CPSM and then also all the people who contributed. So Crystal Labarero was the first consultant we used. Dr. Cheryl Ward was amazing at helping us really make the contextual document fantastic. Doctors Mary LaValle, Yvette Emerson, Sarah Goulet. I know I'm going to forget people, but the members of our committee are listed on the website and in the slides that we have for public viewing. But I can't say enough about how generous folks were about all of that. So thank you, appreciate that.
And we wouldn't be here without you and the guidance that has been provided to us so that we can do this in a meaningful way, in a way that resonates with the needed to.
Shout out to our previous registrar also.
Yes.
Dr. Jomak, so she was the registrar when this whole thing began. And so happy to have worked with her for as long as we did, and now shout out to Dr. Mihalchuk. She's doing a fantastic job. So I think we're in good hands.
Okay, well, thank you. We are looking for questions. We don't have any submitted at the moment, but we did receive an email earlier that had this question. It kind of touched on it, so maybe you can share that again. Can you talk a little bit about the timeline? You talked about the restorative practices program and the standard, and now you're in the consultation phase. So what will you be doing with all these comments, and when can registrants expect further action?
So the consultation process is open, I believe, until November the 11th. The purpose of consultation is to put a document out there to get feedback and to try and understand the ways in which it connects or doesn't connect with the audience of our registrant as well as the public. This is an important consultation for the public. The summary of those comments will go back to the working group that was the subsection of the advisory circle that was asked to work on this for review and comment, and to decide what changes might need to be made as a result of the consultation. Generally speaking, our standards do change after consultation, and that's an important part of the process. Once that has happened, the revised document will go back to council in December. At council in December, it will be likely approved, and then council will decide on the timelines for implementation. We're anticipating that this will launch sometime early in 2025. Our goal is to have the restorative practices program with staff hired, and at least our first few steps forward in deciding what that's going to look like in terms of operational function, also around the time in early 2025. So there will be a job posting or two coming forward. If you're listening to this and have any interest in engaging in this work with us, that would be amazing. So that's really the timeline, is early 2025. You can anticipate this moving into practice. And I really want to emphasize that no one on council or no one in this organization expects perfection about how this is going to roll out, or how everyone is just going to immediately change and accept all of the important processes that come with self-reflection and learning more about things that you may not even know that you need to know about. And so again, with that restorative approach, we're looking to be helpful and supportive, not punitive. When we're reporting, we want to know how we can help individuals learn and grow from that experience and do better and be better, and to get support to do that. As you said, and I will reiterate, if something is so egregious and so serious that an educational approach doesn't seem to be appropriate, then obviously it is our job to protect the public and make sure that those situations are dealt with appropriately. But by and large, it's our belief that the vast majority of registrants do self-regulate well, they do follow standards, and they do try their best, and that's what we're after here. It's not perfection, it's working towards continual quality improvement and continually doing better and being better in learning how to address anti-Indigenous racism in actual practice.
Okay, thank you. There is one question that did come in. Just before we do that, can you discuss more, talk more about a registrant's responsibility for reporting when working within an organization that has maybe the structures are some of the barriers?
I can try, and yeah, I'm sure you will help that. So I think what's important is to understand that we're moving to a place where we can't just accept what we're seeing if we know it's not right, and we have to learn how to put up our hand and say that doesn't support anti-racist care for Indigenous people, and we have to figure out in the organization, it really depends on context, how you can manage that. The goal is to empower you to know that you have our support to ask questions and to raise issues, and to challenge what's happening within the appropriate leadership structures within your organization. And that means also challenging each other as fellow registrants and colleagues. We have to have these difficult conversations in order to make change. So we encourage that when you see something, you need to say something. Obviously, we don't control the response on the other side, but the reality is the more people that raise issues, the more people that stop just ignoring what's going on and start to raise consistent problems, It will be incumbent on the systems and our organizations to respond. So particularly that's my response about organizations. I don't know if you have any other comments about.
Yeah, I think because racism is so widespread and pervasive, it's hard to know, like, okay, are we gonna try to pick and choose your battles? So I don't know if that's maybe something you're wondering about. But I think that it needs to be documented. Like, we know it's a massive problem, and we know that based on the fact that health gaps continue to widen in Manitoba in regards to Indigenous people and the rest of Manitobans. And so if there's a measurable race-based difference in health outcomes, we absolutely know racism is at play. And people don't report it for a variety of reasons. You know, avoidance of conflict is like an approach that serves to uphold the status quo. And if we are not actively working against that, then we are part of the problem. And so that's why deep self-reflection is an essential component of this practice and also the learning journey. So if you want to have a conversation about something specific, I'm happy to talk with you about that. But yeah.
Thanks for that.
So we do have one more. There's a couple of comments that we'll share offline, Dr. Monkman, but just going on that, you talked about documenting some of these instances. So somebody does have a question about whether we'll be tracking data and hotspots and themes and any kind of data management in regards to that. Do you have any comments on that?
Well, I think data is important. And
I think it's very important.
I think any way in which we can capture that, we need to, and
Yes.
to use it to inform where we go from here. I think that's incumbent on us to figure out how to do that
Yeah.
effectively, but I
Yeah.
think that's an important challenge and one that we should take on. Because we are committed to understanding what's going on and how we can help better.
Yeah, like in Manitoba, we are fortunate to be in the presence of all kinds of Indigenous health experts at the University of Manitoba, but also at FNISM, the First Nations Health and Social Secretariat of Manitoba. And so a lot of the research that they do is grounded in the principles of FOCAP. And I think that if we're not measuring it, then we will never know the extent or scope of the problem. And so I am fully supportive of that. And I thank whoever brought it up, because I think that I love when things are data driven, you know, because yeah, it's impossible to argue with.
Thank you. So we'll share all these comments, lots of positive comments about everything that was shared today. So I think we can wrap it up. We don't have any other questions. I think we touched on all the ones that we have, but we certainly welcome any more by email to cpsmconsultation@cpsm.mb.ca. And of course, we encourage you to review the draft standard and provide feedback, which you can do by email or by filling out a survey. And Michelle is going to share the link directly to that survey in this chat, but we do encourage you to review the standard first. And you can also call, we do have a toll-free number set up, or if you would prefer to just kind of share your thoughts in a recorded message, that you can do that as well. And all that information is if you scan this QR code or click on the link in the chat, it'll take you directly to our consultation documents. We will also share these slides. I think there's some interest in the chat about having access to the slides and the recording of this as well in the next couple of weeks. So please be on the lookout for that. So with that, I thank you all for attending tonight. And of course, thank you, Dr. Monkman. Thank you, Dr. Mihalchuk, for your time this evening.
Bye.